We're excited to announce that our podcast, The Table with Renee Da Silva, is evolving. We're introducing 3 new streams of content on this podcast, designed for Health System CXOs and hosted by the Health Management Academy's subject matter experts for health system nurse executives, health equity officers, and strategy executives. With this change, we'll be activating health system leaders towards outcomes and scalable solutions you can implement now.
Hello, and welcome to the Health System CXO Podcast, featuring 3 streams of content designed for health system nurse executives, health equity officers, and strategy executives. I'm Jackie Kimmell, Senior Director of Member Insights at the Health Management Academy, and Strategy Executives host, sharing the latest market trends and essential insights happening across healthcare so that you can chart a strategic path forward for your health system and move quickly and expertly in the right direction. Hello, everyone, and thank you so much for joining me with the Health System CXO Podcast. My name is Jackie Kimmell, and I hope you all are having a wonderful holiday season. I very much appreciate you joining me during this busy time, and I hope that you've been able to spend a lot of time with your family and relaxing in the midst of what has been a very crazy last few months for healthcare. I hope you all have been able to rest and recover just a little bit before we return back to the healthcare world in January 2025. Now, my topic today is one that is potentially not the most merry for the holiday seasons, and that is site neutrality. But before you turn off this podcast, let me explain to you why I want to talk about site neutrality today. I think in general, site neutral payments have been very much something that many hospital and health system leaders have been concerned about for a long time, and yet there's been very little political and policy movement specifically towards total site neutrality over the course of the last few years in particular. However, I think this is starting to change, and we're seeing far more bipartisan momentum, in particular over the course of the last few months, to try and push for broader site-neutral payments. And I think we could be seeing really a watershed moment for some of the momentum shifting in this direction. So with that specific legislation advancing, I think it's important for healthcare executives to understand both the immediate threats and the long-term strategic implications. Let me be clear today, I don't want to ring any false sort of alarm about site neutrality coming, but I do want to educate listeners today to understand what are the different legislation and policies that are being proposed out there and what impact would they have on health systems so that you can set a strong and smart health system strategy over the course of the next several years. So let's start with the scope of what is at stake. On the very high end of estimates of what could be at stake in terms of site neutrality, we have the estimates from payers. So, for instance, the Blue Cross Blue Shield Association projects that taxpayers could save $471 billion over the course of the next 10 years were site-neutral payments to be enacted. Now, I think that is a vast overestimate of what the actual amount would be, because that would assume pretty much site neutrality across the board. And I don't think anyone within our political landscape thinks that there should be purely site neutral payments across the entire health system. I think most people understand that it costs much more to run any sort of services in higher acuity settings and understand the importance of having those higher acuity settings available to provide services. However, I think a much more reasonable understanding of what a future world of site neutrality could look like comes from looking at what MedPAC has been proposing. So MedPAC has been ringing the alarm about site neutrality for several years now. They've been proposing almost year over year in their annual report some sort of push towards site neutrality in several different forms. And I think it's important to actually go to the source and understand what MedPAC is actually saying. So their perspective is pretty well summed up by these 2 sentences. They say, Quote, in general, the Commission maintains that Medicare should base payment rates on the resources needed to treat patients in the most efficient setting. If the same service can be safely provided in different settings, a prudent purchaser should not pay more for that service in one setting than the other. What I read that to be is essentially they understand that it takes different amounts of money and different resources to treat patients in different settings. However, they think that if the same service can actually be safely provided in a lower cost setting, that all patients should move to that lower cost setting and that payment should be based on the cost of providing care in that lower cost setting. But they don't actually really think that this should happen across the board. In fact, they actually did an analysis across the OPPS, or the Outpatient Prospective Payment Rule, and they looked at the 169 ambulatory payment classification codes for services. They identified of those 169 APCs that only 57 of those would it be reasonable to align payment rates across the three ambulatory care settings with the rates in the physician fee schedule? So basically what they did, my understanding, is they looked at which codes are most often delivered in physician offices, indicating that it is safe to provide those services in physician offices, and therefore that payment rates should be well aligned with physician offices only. They saw that there are 57 of those APCs, and they also identified 11 additional APCs within ASCs, where ASCs have the highest volume for services and where they think that there should be payment alignment between the OPPS and the ASC payment rule for those services only to be paid for at ASC rates, even if they're provided in an HOPD site. So that is kind of broadly what MedPAC has been pushing for. And they say that if those changes were implemented, they would save Medicare about $6.6 billion, as well as beneficiaries about $1.7 billion in cost-sharing reductions. Overall, they estimate that for hospitals, this would translate to a projected 4.1% decline in Medicare revenue across all facilities. So, pretty sizable revenue reduction, especially when you consider that many health systems are already operating on a knife's edge, that government has been taking up that payer mix has been shifting to be far more governmental, which means that any sort of impact to Medicare revenue would likely really reduce overall revenue. We also, of course, have to understand that if Medicare were to make a major shift to the way that they were paying for services, that commercial payers would likely follow. Many of them are already trying to enact their own types of site-neutral payments in terms of overall revenue, but they haven't been able to go quite as far because Medicare follows that same payment differential. So now that we understand a little bit more about what the overall impact might be of these site-neutral reforms, I think it's been clear from what I've said so far that there's still a lot of ambiguity of exactly what site neutrality would look like. And as a result, when you look to the policy sphere, what you understand is different policymakers have been proposing very different things in terms of site neutrality. So within the broad umbrella of site neutrality, there are many different types of components that are included. And I think it's worth understanding really the three different buckets of types of legislation that get included underneath that umbrella. The first is greater transparency in costs across those different settings of care. So I think a great example of what that looks like from a legislative point of view is the Lower Costs, More Transparency Act, which passed the House in December of 2023 and has not yet passed the Senate, but has been, I believe, last year a motion to reconsider was laid on the table. It was agreed to without objection, and it ended up passing the House as a whole. What that act proposes is collecting far more data across hospitals and health systems around both negotiated charges as well as prices, as well as discounted cash prices across different types of services across settings of care. It importantly is not just inpatient care, it includes outpatient care. It also specifically extends the requirements for hospitals to annually publish their prices to include clinical laboratories, imaging services, and ASCs that participate in Medicare. So really extending some of that price transparency legislation to a broader scope, with the idea that legislators want to understand what are the actual prices that are being charged across care settings, what is the really cost that is being driven by hospitals and health systems to furnish those services across different settings, and where could there be opportunities to align payment rates in a more specific way. So that's kind of that first bucket that's coming through with that type of legislation. And, many proponents of site neutrality broadly say that they believe that it's a good start or a first step to try and, establish a foundation to push for more price transparency in the future. The second major group of legislation that has come through is specifically related to the 2015 Bipartisan Budget Act. So the 2015 Bipartisan Budget Act essentially did establish a certain amount of site neutrality, as most health system executives would know. What it did was essentially establish a pure rate across different settings of care, and essentially say that there were certain physician-based departments or PBDs that would be exempted from this rate. Those would be ones that existed before 2015, were grandfathered in, were a certain distance away from the health system, etc., from the hospital. And that those would be paid at a higher rate, but pretty much everything else would be paid at that consistent rate across settings. That has been a big flashpoint for continued legislation, whether those grandfathered PPDs should continue to get that higher rate. There's been many legislative pushes to try and remove that clause and try and adopt full price transparency across those rates. Generally, what I have seen is that those are actually a pretty small percent of overall costs. Avalier put out a report in January of 2024 that found that only 2.3% of CMS payments for outpatient services to hospitals and health systems were made at that site neutral rate for off-campus PPDs. So a pretty small share of the overall payments made by sites of care, and actually 10% are made through accepted off-campus PPDs, whereas 87% made through on-campus HOPDs. So very much a small proportion of the overall spending that goes through. But there have certainly been a number of proposals to try and change that. And then third, you have kind of a broader push towards site neutrality, more in line with what I was just discussing that MedPAC has been proposing for a number of years now. And that is what I think is most impactful in terms of changes in the last few months, is a much stronger push, particularly in the Senate, for types of changes that are much broader. That charge has really been taken up by Senator Bill Cassidy, who's a Republican from Louisiana, as well as Senator Maggie Hassan, who's a Democrat from New Hampshire, both of whom have really pushed this issue specifically from the Senate Help Committee and are trying to introduce far more aggressive legislation in the next term on this issue. They have both proposed a framework that would seek to really push forward two types of proposals. The first would be what I was just talking about, so changing those grandfathered PPDs and removing the exception that they have, not a huge impact from doing those. But the second and most important push that they would make would be establishing site-neutral payments for common outpatient services, very similar to what MedPAC just talked about. So what they're suggesting in their framework is that they would look at the last 4 years of data for all of the most commonly performed outpatient services and determine the setting where each procedure was most commonly performed. And then they would set the reimbursement rate according to the site where the procedure was most commonly performed. So very similar to MedPAC, if procedures were most often being performed any general APC was most commonly being performed in physician-based office settings, then the rate would be the PFS and not any sort of higher rate. They also, not super clearly, but pretty stridently within their framework, attack facility fees and say that facility fees are the major reason that the rates are so much higher for Medicare and for commercial payers to get care in hospital-owned facilities. And they have a number of examples in their framework of where the entire payment differential, because there is, generally pretty site-neutral payment across sites, comes from that facility fee being added. And so it's not super clear within their proposal what they would actually propose doing with that, but it seems clear that they might propose to completely ban facility fees more broadly, as many states have sought to do specifically around telehealth, where they ban any sort of facility fee specifically for telehealth types of visits, where the patient doesn't actually step foot in that facility. So that is what they're proposing. Who knows what is going to be when next year comes around and when we have a new administration that is, in seat and considering all of these proposals. But I think it's worth understanding that there is far more movement around site neutrality within the Senate, that these proposals are pretty specific, pretty clear, and far broader than previous pushes just about grandfathered facilities. And that, as there's kind of this growing focus on healthcare affordability, as well as multiple stakeholders really competing for funds, that this could be a site where there could be more legislation coming through. For healthcare executives, I think this creates three clear critical priorities. The first is doing an impact assessment and kind of looking at the APCs that MedPAC has been proposing and doing a review of the exposure to your system across those targeted APCs and what it would look like with different types of payment rates and specifically without being able to charge a facility fee for many of those types of services, as well as modeling out what would it look like to have that 4.1% decline in revenue and how would that impact the system as a whole. I think second is understanding the impact region by region. There are pretty strong geographic variations in the impact of this. The New England and East North Central regions are generally most exposed to having the most of these grandfathered in facilities in particular. And so I think, and the least of those accepted facilities. So I think leaders in those regions in particular, or those with facilities in those regions, should understand particularly what that impact would be. And then third would be doing some service line planning, really trying to understand where specifically those codes shifting in ASCs from a HOPD rate to an ASC rate, even for services performed at HOPDs, would create different vulnerabilities within specific service lines, and really using those projections to advance a much stronger ASC type of strategy. I think in general, most health system strategy leaders are trying to push, obviously, to a much more ambulatory focused strategy and capital expenditure strategy moving forward. But I think these broader shifts towards site neutrality are a clear reason why health system strategy leaders should continue making pushes in this space. So with that said, I think the site neutral payment debate is reaching a more critical juncture. Of course, hospitals are raising valid concerns about patient access, about operational requirements, but the combination of bipartisan support coming in the Senate, these very specific policy proposals, and of course, payer desire to have these significant projected savings suggests that the issue is definitely not going to fade away. So I think continuing to make those no regrets next steps in order to understand where health system payment is exposed and to try and plan out what the impact could be in the future is going to be incredibly important. With that, I wish you a wonderful holiday season, and I will see you next time. Thank you for joining me on the Health System CXO Podcast, where we activate health system leaders towards outcomes and scalable solutions you can implement now. Remember to subscribe to the Health System CXO Podcast on your favorite podcast platform so that you never miss an opportunity for insights. If you liked this episode, consider leaving us a review and sharing our podcast with your friends and colleagues. You can also connect with us on LinkedIn by clicking the link in the episode description. See you next time.